Commerce and Consumer Protection Committee, March 5th, 2026, G15 Capital. Annual mandate bill hearing, and we will start with a mandate process overview from the Department of Commerce. Mr. P.J. Mitchell, please introduce yourself and proceed.
Good afternoon, Chair Klein, members of the committee. My name is P.J. Mitchell. I'm the Director of Regulatory and Health Policy for the Minnesota Department of Commerce. I'm going to provide a quick flyover of the health benefit mandate review process, just to give folks some base as we head into the presentations today. So just to level set with some federal requirements that tend to interact with the state process. The Affordable Care Act created
Mr. Mitchell, you just want to get your voice
sure.
right up to the mic.
You got it. Is that better for you? Okay, thanks. The Affordable Care Act created the concept of essential health benefit packages, and the ACA requires qualified health plans offered in the individual market, as well as small group health plans to provide coverage of 10 categories of EHBs. Those EHB categories are broadly set at the federal level, but states designate a state-specific EHB benchmark plan that sets forth the specific items and services included within the 10 EHB categories. The ACA allows states to require coverage above and beyond the benefits included in the state's EHB benchmark plan, but for new benefits that have been required after 2012, the states are required to defray the cost of the benefits added for QHBs, and that's subject to federal regulations. As part of that health benefit evaluation process, Commerce determines or initially determines if a mandate exceeds the coverage required under the state's EHB plan and requires defrayal. So the state requirements under 62J require the department to evaluate and report the potential impacts of legislative proposals that would require health insurers to add or increase coverage to certain conditions, diseases, or other healthcare needs. The evaluations focus on potential fiscal impact as well as public health impacts of the proposed legislation. Commerce does contract with a vendor to support this work, the American Institutes of Research, as it is detailed and pretty technical in nature. I'm not going to spend too much time kind of fully rolling through this slide, but just wanted to lay out the types of bills that Commerce is required to evaluate as a mandated health benefit proposal.
Give us just 10 seconds. We're going to try to get your slides up here.
Oh, it sounds great. Is that any better? Oh.
Proceed.
Okay, thanks, Chair Klein. So under the state statute, a mandated health benefit proposal includes a number of different types of proposals. And so the slide here lays out the types of bills that Commerce is required to evaluate under the statute. This includes bills that provide coverage of healthcare treatments and supplies, but also includes bills that may impact cost sharing or benefit design. It's important to point out here that the state definition laid out for a mandated health benefit proposal is more expansive than the federal definition that applies when we evaluate those defrayal obligations. For the purposes of the defrayal obligations, the state required benefits are those state required benefits that are mandate defrayal are required coverage of specific care, treatment, or services. It doesn't include items like cost sharing or more benefit design in nature. I'll also note that under the state law, the mandated benefits expressly do not include amendments to healthcare professional scope of practice or proposals that make state law consistent with federal law. Walking through then a quick process overview of what we call our 62J review. So the legislators would submit proposed mandates by August 1st of each year. The House and Senate Commerce chairs prioritize those lists based on the number of mandates submitted, capacity available for evaluation, and the relative difficulty or complexity of the evaluation. Commerce has 180 days to develop and submit the reports to the legislature. And that process includes issuing a request for information to gather and summarize feedback and data from stakeholders, including advocates, providers, and health plans, as well as analysis from MMB on coverage and fiscal impacts, conducting literature review as applicable, and doing a claims analysis for per member per month impacts, as well as that defrayal analysis component that the Department of Commerce conducts. And we acknowledge this is, again, a labor and resource-intensive process that includes pretty substantial stakeholder feedback as well. There are limiting factors that I just want to call out as you all are looking at the reports. There are limitations at times in the available data or the claims for a specific mandate. There are also some limitations at times between the specificity of coverage of diagnosis, treatments, and procedures, and then the assumptions that may go along with that, that specificity. So that's where you may see a range of assumptions and a range of estimates, particularly within the public comments. The reviews and estimates are based on the original language that's submitted, so they don't reflect kind of updates throughout the process. And then while always looking at kind of the public health impacts, the potential downstream cost savings associated with coverage of a proposed mandate do exceed the scope of that project for purposes of those fiscal estimates. So with that, I think I can leave it. I do have an appendix included for folks, but I'm happy to take questions at this time.
Well, thank you, Mr. Mitchell. Questions from the committee? Thank you for your testimony, and we'll call forward Mr. Dan Andreessen.
Thank you, Senator Klein.
Welcome to the committee, Mr. Andreessen. Please introduce yourself and go ahead.
Mr. Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. We're the trade association representing Minnesota's nonprofit insurance plans. Our membership includes Blue Cross Blue Shield of Minnesota, Health Partners, Medica, and Sanford Health Plan. And thank you for the opportunity to address the committee today, making this accommodation. There are three issues that I wanted to raise that kind of cut across all the bills in front of you today. There's a letter in your packet with more specific feedback on each of those proposals. The first area that I wanted to address is regarding cost. The council does not take a position on the merits of a mandate. All the bills before you today involve someone who is struggling with a health condition, who is just trying to get the access to care they need so they can live their best lives. It is also true that the providers and drug companies who perform these services in the bills that are before you today expect to be paid to deliver this care. The money health plans you use to make payments for healthcare services and pharmaceuticals come from the premiums that we collect from our enrollees. I sometimes hear it categorized as health plans' money and that health plans need to use their money to pay for care. It's not our money. It's our enrollees' money that they give us to pay for care, and because the cost of care is so high, it can only be stretched so far. In these bills, you are instructing health plans to use premium dollars to pay for services we have not previously. Doing so means insurers will need to collect more in premiums to pay for these services. These mandates can only apply to the commercial insurance in the fully insured market, which is around 17% of the Minnesota's population. Almost 94% of this market is covered by our 4 nonprofit health plan members. It is clear this market has affordability challenges, exacerbated by increased healthcare costs, higher utilization, and sunsetting of federal enhanced tax credits. Premiums this year increased significantly in the individual and small group markets. This resulted in an 8% reduction in enrollments through MinnesotaCare and a 112% increase in consumers buying down, looking for lower cost options. Now is not the time to add 9 new mandates to the fully insured market. While each of these mandates on their own may not add exorbitant costs, the cumulative impact of these mandates contributes to the affordability challenges Minnesotans face when they're buying insurance on their own. I also want to point out that 5 of the bills before you today mandate coverage with limited or no cost sharing. If healthcare is paid for by, if it's not being paid for by premium dollars, it's paid through copays and coinsurance, which are enrollees pay directly to their provider. Some plans are designed with higher cost sharing in order to provide a plan that has a lower monthly premium. As established by the ACA, all products for sale in the individual market must fall into 1 of 4 tiers, which are defined by a set ratio of premium to cost sharing. Because you will be mandating an insurer eliminate cost sharing for a given service, in order to maintain a product in that given tier, we're going to need to increase cost sharing for some other service. Eliminating cost sharing does not make that service free. I will also note that some of these proposals will require cost deferral by the state under requirement under the ACA. We don't have an estimate for this cost or how many of the mandates would be required for deferral. It looks like maybe infertility would be, maybe augmentative alternative communication systems, but the rest are still unknown. There was a fiscal note for the infertility mandate in 2023 that showed that deferral for the cost of the state mandate would be $18 million annually. For today's hearing, a fiscal note has been posted for the augmentative alternative communication systems, but that analysis stated that it was not yet complete. The second area I'd like to highlight is the use of prior authorization and utilization management. I know this topic has elicited negative reactions, and I'm not here to relitigate that issue. But it is a tool that health plans use to manage costs, to intervene when services are fraudulent, overprescribed to maximize reimbursement. Hardworking people are sending us their premiums, expecting that these dollars are being used appropriately and not wasted. Now, the vast majority of providers are out there doing the right thing. But unfortunately, there are bad actors who are out there manipulating the system. And even though this involves a small percentage of providers, it results in big costs that we all pay in our insurance rates. 6 of the bills before the committee prohibit health plans from using utilization management, prior authorization, or quantity limitations. In addition, some of these services being mandated are not well defined and could be interpreted broadly. This ambiguity, coupled with limiting a plan's ability to perform oversight and control, opens the door to fraud. If you're not wanting a health plan to use premium dollars that we collect from our enrollees on a service, we should be able to maintain the ability to ensure that these are not being used for fraudulent care or misuse. Lastly, I wanted to raise concerns about the involvement of private equity in healthcare and coverage mandates. Private equity acquisitions have increased over the past decade, with many targeting entities who are struggling financially or who show short-term profit potential. Although private equity acquisitions may bring operational efficiencies, some of these acquisitions generate quick profits by taking advantage of our primarily fee-for-service payment model, which rewards volume over outcomes. This is especially seen in healthcare services, which have a short-term relationship with the patient. This can include diagnostic imaging, gastroenterology, OBGYN, infertility clinics, durable medical equipment, and surgical centers. Private equity firms use a variety of tactics to boost revenue, including overprescribing tests, performing low-value procedures, or using inaccurate billing codes to get inflated reimbursements, which is a tactic known as upcoding. Beyond practice acquisition, we have seen private equity-backed providers support mandate bills which may benefit them financially. This was the case in several mandates enacted by the legislature in 2024, including the mandate for no-cost secondary mammograms. There is little transparency or oversight of private equity involvement in Minnesota's healthcare system, and so it's difficult to discern how many private equity-backed providers are supporting the bills before the committee today, beyond doing just a simple internet search. Maybe an analysis of private equity involvement of a given mandate could be added to future 62J mandate reports. We urge the committee to be mindful of for-profit companies behind the scenes looking to take advantage of benefit mandates to generate profits at the expense of their patients. Health plans already have medical loss ratios which essentially limit our administrative costs, and our members operate at 1% to 3% margins. There are no such requirements for for-profit, private equity-backed healthcare entities. We need to work together to lower healthcare costs, not raise them. In conclusion, again, thank you for this accommodation with the testimony. As these bills move forward, we'll continue to look at the language and reach out to the bill authors to work on addressing any operational challenges and to avoid unintended consequences. Thank you.
Thank you, Mr. Andreessen. Mr. Carr, who's online, you are not on mute. I appreciate your feedback, Mr. Andreessen. As always, the pathway for these mandate proposals is shared jurisdiction between Commerce Committee and HHS. The motion on all of them will be to go to HHS, where they will weigh in on the benefits of the bills. And let me validate what Mr. Andreessen was saying. We are concerned on this committee about costs to Minnesotans, and each individual mandate does have merit, but each one does add to the costs of insurance for Minnesotans. That is why in this committee last year, we passed the Nick Frentz bill that would require the state of Minnesota to defray costs of any new mandate that we would pass. And I still believe that is the right thing to do. If we think something is so beneficial that it should be mandated on all health plans, and it is so essential to the public weal and public good that the state of Minnesota should require it, then the state of Minnesota should pay for it and not individual insurance holders. And that bill is in before the HHS committee. With that, we will go to Senate File 1946. Senator Kupec. Welcome to the committee, Senator Kupec. Senate File 1946 is in front of us.
Thank you, Mr. Chair. This bill would require coverage and reduce barriers to access to alternatives to opioids for the treatment and management of pain. And I do have an amendment to this bill as well, Mr. Chair.
Senator Kupec offers, oh, no, I'm sorry. Senator Seeberger offers the A1 as an author's amendment. All those in favor say aye. Aye. Opposed? This bill is in the form you would like. Senator Kupec.
Sure, and I'll just speak briefly here to the amendment. The amendment clarifies that this only applies to non-opioid prescription drugs. There's a couple of technical changes. Clarifies that health plans do not have to provide coverage for alternative prescription drugs if such drugs aren't actually available, and it updates the effective date to January 1, 2027. So this bill is bringing forward to help address the ongoing opioid crisis in Minnesota. The societal burden of opioid epidemic in Minnesota is substantial. According to the Minnesota Department of Health, most recent information, Minnesota had 678 opioid overdose deaths in 2024, 3,451 non-fatal opioid overdoses also in 2024. CDC reports that in 2023, approximately 1.523 million opioid prescriptions were written in the state of Minnesota. CDC data also shows that around 9% of patients who are newly prescribed opioids to manage acute pain become addicted. Legislative action is critical in correcting this trajectory, and I believe this bill is a step in that direction. So here's what the bill does. Pain, one of the most common reasons for patients seek medical care, and every patient deserves equitable access to safe, effective treatment. The bill is intended to ensure that patients have the same access to clinically proven non-opioid treatment as they do for opioids when experiencing pain. No patient should face delays when accessing non-opioid treatment. Pain parity ensures that when a provider prescribes a non-opioid for a patient, they aren't told that they'll have to wait 48 hours for prior authorization, but they can immediately fill a prescription at a pharmacy. While many health plans are offering non-opioids without barriers, there are still thousands of people without access to these drugs. This bill aligns with the evaluation conducted by the Department of Commerce. Chronic pain affects over 100 million Americans daily and costs the U.S. over $600 billion each year in lost productivity and health expenses. The cost of newer brand name non-opioid medicines result in an average cost difference of $16.68 per day, more than treating pain with an opioid or acetaminophen post-surgery. I just want to point out prescriptions are limited to just 14 days for people with moderate to severe acute pain, and so that's $420 over a 14-day period, and this is before any rebates. I also want to point out that from the CDC, cost estimates per cases for opioid use disorder. Healthcare, if somebody has an opioid addiction, it's $14,705 for that person. Substance use treatment, $1,660, and almost nearly $7,000 within the criminal justice system, oftentimes with that. Lost productivity is over $14,000 as well. Reduced quality of life is somewhere around $183,000 for that person. And if the opioid results in a death, those numbers are even more.
Thank you, Senator Kupec. And are your witnesses here today? Is Bonnie Bolash here today? Come forward. Welcome to the committee, Ms. Bolash. When you're ready, go ahead and introduce yourself and proceed.
Sure. Can you hear me? Yes. All right. Thank you, Chair Klein and members of the committee. My name is Bonnie Bolash, and I'm a licensed acupuncturist. I'm here today in support of Senate File 1946. Minnesotans need access to non-pharmacological options for pain management, and today I'm asking that acupuncture be included in this bill. Acupuncture has been present in the United States far longer than many people realize. In a 1993 report on acupuncture needles from the Food and Drug Administration references its presence in the United States as early as the 1700s. Since the 1970s, acupuncture has gained increasing recognition within the American healthcare, including the introduction of insurance coverage for acupuncture services. In 1972, the IRS recognized acupuncture as a deductible medical expense for tax purposes. Meanwhile, in Minnesota, Medicaid and workers' compensation programs began covering acupuncture in the 1980s. More recently, the Centers for Medicare and Medicaid Services expanded Medicare coverage for acupuncture for certain conditions in 2020. These steps reflect a growing recognition that acupuncture is a legitimate and valuable option in modern pain care. Today, acupuncture is practiced within major medical systems, including Allina Health, Mayo Clinic, and the Department of Veterans Affairs. The VA has integrated acupuncture into both clinical care and community care programs. As early as 2011, approximately 40% of VA clinics were offered acupuncture services, and access expanded further through the Veterans Choice Program and subsequent reforms. When acupuncture is used early in the treatment of pain, overall healthcare costs can decrease, as patients often rely less on imaging, injections, surgery, and long-term medications. Yet too often, acupuncture is used only as a last resort. When the CDC developed opioid prescribing guidelines in response to the opioid crisis, they recommended trying non-pharmacological pain management first. However, many medical organizations noted that a lack of insurance coverage limits patients' access to these therapies. If we want non-pharmacological care to be the first step in pain management, it must be accessible and covered. Thank you for your consideration and for your commitment to improving access to patient-centered care. And I also wanted to say that there is a 62J report on the acupuncture coverage bill.
Thank you, Ms. Bolash. Member comments or questions? Senator Rasmussen.
Thank you, Mr. Chair. I do think there is some remarkable technology and advancements that have been made in developing non-opioid pain medications. And I think it's going to save lives. It's going to improve care for a lot of Minnesotans and a lot of Americans. Mr. Chair, you had mentioned defrayal as kind of being an opportunity here. And so I wanted to offer the A2 amendment. I'm happy to describe the amendment.
Senator Rasmussen offers the A2 amendment. Is it in our packet? It is being distributed. To your amendment.
Thank you, Mr. Chair. This amendment is quite simple. It would defray the cost of this proposed mandated health benefit, and it would follow federal regulations in terms of how defrayal costs are calculated. And I think this would be a good bill for us to take a look at when you have a benefit that I think will benefit Minnesotans, to make sure it doesn't also increase the cost of health insurance for Minnesotans.
To the A2, Senator Latz.
Mr. Chairman, will Senator Rasmussen answer a question?
Senator Latz.
Senator Rasmussen, can you describe exactly what defrayal is and how it processes with regard to costs and appropriations?
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Latz. Yes, how these defrayal costs are calculated is they will look at the proposal, and if there is a net increase in the per member per month costs, if this proposal is enacted into law, the commissioner would make payments to the health plans to defray the cost of the benefit that is being offered. That would cover the individual, small group, and large group markets. This is something that is oftentimes already required and the process under federal regulations for defrayal would be used to ensure that there's equitable distribution of the cost to the health plans.
Senator Latz.
Thank you, Mr. Chairman. Senator Rasmussen, is there an identified source of funding for these commissioner payments in the event there is a defrayal?
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Latz. Previously, there's kind of been two options. One has been through the Commerce Committee's budget target. We've also seen these types of defrayed mandates be carried in a Health and Human Services budget bill, and so we have seen defrayal in various state budget bill proposals before.
Senator Latz.
Thank you, Mr. Chairman. Senator Rasmussen. So is this essentially for this particular proposal what we passed last year and sent on to HHS committee that hasn't gone any further with that the state will pay for all mandates that are imposed?
Senator Rasmussen.
Thank you, Mr. Chair. This is similar. I don't have the exact language from the previous bill that we had up, but a similar idea in terms of making sure that we're defraying the cost of new mandates that are coming into law.
Senator Frantz.
Thank you, Mr. Chair. Thank you, Senator Rasmussen. First of all, Mr. Chair, thank you for flagging the defrayal issue. I think it was appropriately discussed in this committee, and as Senator Latz pointed out, it was passed on to Senator Wiklund's committee. I think that was the right move for this committee at the time. Senator Rasmussen, we have not had a chance to discuss this A2 amendment or its similarity or differences from the bill that I wrote last year, but happy to engage with you on it. I think having it in Senator Wiklund's committee gives me confidence that the matter will be dealt with on the half that's not Commerce and HHS, and for that reason, I'll be a no vote on the A2 amendment should you put it to a vote. Folks, we got to ask ourselves, if we're willing to toss around the insured's money, why wouldn't the state step in? If a mandate for a benefit is so good, where's the state's money where its mouth is? That's the spirit of the defrayal bill that I offer, and I stand behind it. Procedurally, though, I think the better move is to leave it in the HHS committee where Senator Wiklund, I'm confident, will deal with it in whatever way suits the members of that committee. Again, Mr. Chair, Senator Rasmussen, thank you. I'm a no vote on the A2.
Further questions or comments on the A2? Senator Latz.
For either Senator Rasmussen or for Senator Kupec, is there any projection what the dollar amount might be if there were to be a defrayal, or what the cost would be to the health plans if this mandate were passed?
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Latz. Effectively, this would be a fiscal note that would come onto the bill, and the 62J reports and other information would be used to calculate the cost of defrayal. One of the features of the bill that this committee heard last year is that there's only costs if new mandates are actually put into law. And so it would follow a similar process that we've done in the past when it comes to defraying costs for health benefits.
Mr. Chairman.
Senator Latz.
Is there a 62J report on this bill? I thought I heard there was, but maybe someone can summarize it for us.
Counsel.
Thank you, Mr. Chair. Senator Latz, there was a 62J report done on this bill. The comments on defrayal that I saw is that any defrayal was associated with non-drugs, which the author's amendment eliminated. So my understanding, based on that 62J report, is that any remaining defrayal would be negligible. But you know, that's just my reading. Thank you.
I have a question either for Senator Rasmussen or for counsel. As I read the A2 at line 1.22, this appears to apply more broadly than simply to the Kupec bill in front of us. This actually is the Frentz bill. It says that all mandates will be subject to defrayal henceforward. So I guess first of all, I would argue that this is not topical to the question before us. And I would also say that if we're going to pass a broad proposal such as this, we should do it in the form that we did with Senator Frantz's independent bill to discuss. So I will also be a no on this amendment. Senator Duckworth.
Thank you, Mr. Chair. I appreciate that. I'm trying to follow the conversation here, to be honest with you. And so I do have a quick question for Senator Rasmussen, if that's okay. Basically, if I understand it correctly, your amendment is basically just asking for folks that voted yes last time to vote yes on this to support the defrayal concept regarding any insurance that's mandated by the state of Minnesota. Is that right?
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Duckworth. Yes, I think this committee had bipartisan support on the idea of defrayal and moving it out of committee last year. We haven't seen any action that I'm aware of in the Senate Health and Human Services Committee on that bill, and so as we're having Health Insurance Mandate Day, this would be another way to express this committee's support to the idea and to have it be a part of the conversation as these mandates are being evaluated.
Senator Duckworth.
That's all I got, Mr. Chair. Thank you.
All right. Any further? Senator Frentz.
Thank you, Mr. Chair. Thank you, Senator Rasmussen. The committee's will was expressed in the bill last year and sent it with confidence to Senator Wiklund's committee. Attaching this language to this bill is a somewhat different matter, and for that reason, again, I'll remain a no vote on this. Folks, this comes down to a very simple question. Do you want state legislators to make decisions with taxpayer money when they increase these benefits, or do you want it to be thrust upon the plan participants without them having the same voice up here? I think the better plan with defrayal is to say, if the state's going to mandate an additional benefit and the state believes it's in the best interest of the public, put the state money behind it. That will also benefit the ratepayers. So that's where this bill comes from, and I know we're semantics on procedure. I'm an advocate for the bill, that's why I authored it, but I think the process is better to have it stay as a standalone in Senator Wiklund's committee, where members of that committee are best suited to make those choices. So I do not support tacking it on, my words, not yours, Senator Kupec, to this bill. Thank you, Mr. Chair. Thank you, Senator Rasmussen. Open to conversation anytime.
Senator Wiklund.
Thank you, Mr. Chair. And I was not a supporter of that bill last year, and I'm not a supporter of putting that bill on this bill this time and in this manner. If we want to have the discussion again, the bill is in my committee. I will think about whether we will have a hearing on it. I have concerns because I think if we want to see mandates evaluated, I think the legislators have tools to decide whether they, how they wish to see mandates treated. We have fiscal notes, we have the process that we've used, and we have public hearings, and we get informed, and then we make a determination. A couple years ago, we did put money aside in the HHS budget for defrayals. I don't have the particular mandates that we did that for with me today, but I can get that information. So we do make that determination at times to do make that defrayal cost in our budget. But I don't think saying that we should do that globally is the right way to go, and we've had that discussion last year, and I expressed my concerns about making that choice, and that was a separate bill, and so I will just say again, I don't support that. I don't support your A2 amendment.
No further discussion on the A2. All in favor say aye. Aye. Opposed? No. Amendment is not adopted. To the underlying bill, further member discussion or questions? Closing comments, Senator Kupec.
No, thank you very much for the discussion and the debate on this. I think this is a needed bill, and I think if if we were to implore some kind of dynamic scoring upon this bill, that this even if these drugs cost a little bit more money, that they're going to save a lot of money in the end from the people not being addicted to these drugs or having to go to treatment.
Senator Kupec, I'm sorry, I'm going to talk after your closing comments because I meant to say this. I agree with you. So I did my last shift after 35 years as a medicine doctor on February 1st. And through that entire time, we treated pain with very limited tools. Almost always, if it's severe pain, we treated with opioids. And the devastation and the morbidity and the toxicity that we infused into our population with those medications is staggering. When I saw that some new pharmacologic alternatives to opioids are coming out, I said, hooray. I don't know if they're the all-end-all solution yet. They're probably not. But if they, prevent one further prescription from oxycodone from going out the door, I think they're well worth it. I will say that, even in my last couple of months as these medications were being rolled out, cost was a factor in not prescribing them. And it's much easier to write a 30-day prescription for oxycodone, which costs pennies, but the downstream, of course, morbidity is significant. So thank you for the bill. I hope this is part of the solution and an improvement in the practice of medicine. All in favor of the motion of Senator Wiklund that Senate File 1946 as amended be recommended to pass and be referred to the Committee on Health and Human Services, say aye. Aye. Opposed? No. Motion is adopted. Thank you very much. Kupec. Senator Mann. Thank you, Senator Mann, for being flexible here. Looking for authors today. We will begin with Senate File 3716, which is in front of the committee.
Thank you, Mr. Chair. I do have an author's amendment to clearly define what the follow-up tests are that we're talking about.
Senator Rest offers a two authors amendment. All in favor say aye. Aye. Opposed? Senator Mann, to your bill.
Thank you, Mr. Chair. 3716 is a bill that requires coverage of follow-up diagnostic tests after an abnormal Pap test. So imagine you have an abnormal initial Pap, meaning that there's possible cancer cells that have been seen, and the recommendation is to follow up with a colposcopy or a biopsy of the cervix to diagnose or rule out this lesion. Private plans don't have to cover the follow-up colposcopy. So now we have women who have been told that they have an abnormal cervix and they potentially have cancer, and they can't get the follow-up test to get the actual diagnosis. And I will also note, Mr. Chair, that this bill is part of a very disturbing trend of bills where women have to sit up here and ask that insurance companies cover the health care that we need to stay alive or to stay healthy, health care that we are all paying for already. With that, Mr. Chair, we can move on to testifiers.
Thank you, Senator Mann. Can Ms. Jessica Clem, are you with us remotely?
I am, yes. Can everyone hear me?
We can. Please introduce yourself and proceed.
Wonderful. All right. Good afternoon to the committee, and thank you for having me. My name is Jessica Clem, and I've been a patient and volunteer with Planned Parenthood for many years. I'm here today because I support reproductive rights and coverage for preventative and diagnostic care, and I want to share my story with you all. After earning my graduate degree in 2010, I had a routine annual pelvic exam at Planned Parenthood that came back abnormal. They referred me to get advanced testing at a more specialized center, where they found a tumor the size of a walnut in my cervix. They promptly scheduled me for a LEEP procedure to remove the tumor. Everything went well and I was healthy, but the doctors told me that if I had waited just a couple more months, I would have gotten cancer. The cost of my exam at Planned Parenthood was significantly reduced for me, and thanks to a federally funded program, the price of the LEEP was covered entirely. And this meant everything to me because cancer runs in my family. My mom died of cancer when she was 36 years old. So the diagnostic care I received saved me from both financial burden and cervical cancer. But I'm just one example of why coverage is so crucial. And there are so many others like me out there and others that are not so lucky. In 2023, over 33% of adults in Minnesota reported foregoing preventative exams due to cost. This is unacceptable. Minnesota needs to do better for its residents. Insurance must cover preventative and diagnostic care because healthy citizens are vital and everyone deserves care. Please continue advocating for health care coverage for Minnesota residents as our lives depend on it. Thank you so much for this opportunity.
Thank you, Ms. Clem. Is Dr. Nicole Chasen online?
Yes, I am. Can you hear me?
We can hear you and we can see you. Please introduce yourself and proceed.
Excellent. Thank you, Chair Klein and members of the committee for the opportunity to testify today in support of Senate File 3716. My name is Nicole Chasen. I'm a board-certified family physician practicing in Minneapolis, where I provide full-spectrum care across the lifespan, including screening for early detection of diseases such as cervical cancer. I'm also an associate medical director for Planned Parenthood North Central States, where I provide office-based gynecology services, including colposcopy, which is a diagnostic procedure used to assess for cervical cancer after an abnormal pap smear or HPV test. Only 60 years ago, cervical cancer killed more women in the United States than any other type of cancer. Today, the typical American woman has an extremely good chance of avoiding cervical cancer, in part due to early detection and treatment of precancerous cervical lesions as a part of routine gynecologic care and the HPV vaccination. Cervical cancer usually takes years to develop. With accessible care, early changes are treated and cervical cancer can be prevented. The ACA already requires that cervical cancer screenings such as pap smears and HPV testing be covered by all health insurers without cost sharing on the part of the patient. However, further diagnostic testing with colposcopy and biopsy is often needed to determine the risk of cancer. And if the risk is high enough, treatment before developing cancer is recommended with a LEAP procedure and close clinical follow-up. Unfortunately, these diagnostic procedures and treatments are not required by the ACA without cost sharing. And we know that cost sharing is associated with decreased utilization of evidence-based medical care. These costs are not trivial. In 2021, a study in obstetrics gynecology reviewed out-of-pocket costs for colposcopy among commercially insured women from 2006 to 2019. Not only did they find that these out-of-pocket costs were common and significant, with the median cost ranging from somewhere around $100 to $700, but costs also increased throughout the study period. Cervical cancer is treatable if found early. However, significant disparities exist, particularly with access to follow-up diagnostic testing, and Minnesota is no exception. In Minnesota, 93% of people with early-stage cervical cancer will survive their cancer at least 5 years after diagnosis. That's compared to 52% diagnosed with late-stage disease. Minnesotans of color are far more likely to be diagnosed at a later stage. Patients of color already experience inequalities in healthcare, even without financial barriers. It is imperative that we reduce as many barriers as we can to make sure our healthcare system supports all Minnesotans. We have the power to eliminate cervical cancer. Medicine and science have come a real long way in 60 years, but policy is important too, and addressing financial barriers is a necessary step. I urge you to support Senate File 3716, and I thank you for your time.
Thank you, Doctor. Is Emily Maye present? Welcome to the committee, Ms. Maye. Please introduce yourself and proceed.
Yeah. Hello, Chair Klein and members of the committee. My name's Emily Maye, and I'm the Government Relations Director for the American Cancer Society Cancer Action Network. I'm here today to share our support for this bill as amended, specifically Section 1, Subdivision 1 and 2, and I want to thank Senator Mann for working with us on this language. The bill ensures that Minnesotans' insurance coverage reflects the latest science and evidence in cervical cancer screening guidelines, including for the option of at-home self-collection HPV testing. Most individuals now have access to cervical cancer screening thanks to its inclusion as a no-cost preventive service under federal law. This bill makes sure that it includes the screening continuum, which includes follow-up screenings, which is in line with the latest coverage guidance from HRSA. The screening continuum is the process during which a patient with a positive screening test continues until they hear they do or do not have cancer, and the bill listed before you lists out what those follow-up screenings include. I want to call out the number that the testifier before me just did. 93% of Minnesotans will survive their cancer 5 years after if caught early. 52% will not if caught late. That's such a number and shows that investments in prevention and that continuum of screening is so important. And this bill before you continues the progress we've made in screening by removing financial barriers throughout the screening process. Thank you.
Thank you. Questions or comments from the committee? Senator Dames.
Thank you, Mr. Chair. Could you tell me, Senator Mann, has this bill been through the mandate process, the mandate review process?
Senator Mann.
Thank you, Mr. Chair. Senator Dames, no, it hasn't. So, while the Department of Commerce told us that they could do 8 to 10 evals per year, I think they only did 4, perhaps, this year. I don't know if they mismanaged their budget or their time or their capacity in any shape in any way. I just want to highlight not only because of that, but overall how flawed the 62J process is. It's brought forward by lobbyists who make more money when insurance companies cover less services. And I find it really quite abhorrent how we allow this statute to stand, and I hope you see today how anti-patient, anti-fiscal responsibility each report costs thousands of dollars to write and oftentimes provide no useful information, and how pro-insurance profiteering that statute is. It's actually quite shameful, Mr. Chair.
Well, thank you, Mr. Chair and Senator Mann. I think this needs to go back through the process, and if that takes some longer time to do it, that needs to be done. We have a process, we have it in place for reasons, and so I heard what you had to say, but that doesn't make it right not to follow the way we set it up, so thank you.
Senator Rasmussen.
Thank you, Mr. Chair, and I just wanted to speak about the 62J reports. I remember this being a conversation when I served in the other body, and we had Representative Steve Elkins was the chief author of the bill. So this has had bipartisan support, and I think it came out from bipartisan recognition from members of the Commerce committees that it's hard to understand what question we're being asked, what trade-offs there are, if we don't have some information on what different proposed mandates could cost. And so, Mr. Chair, I would offer that as an alternative point of view to what Senator Mann put out in terms of the impetus for 62J reports and their value. I think there was a bipartisan initiative to get this put into law, and I think there's bipartisan recognition today that these reports have value as this committee evaluates mandates.
Further questions or comments on the bill? Senator Wiklund.
Yeah, I just wanted to say I support your bringing this forward. I really think that if diagnosing this type of cervical cancer is a way to prevent, more drastic outcomes for women, women should be able to have the full range of tests necessary and have that be covered. And I just want to point out in the health plan's letter, a statement that just, it kind of bothers me that they are concerned about your bill prohibiting a plan from placing quantity limits for Pap tests, which could lead to overuse of services. And I just want to say, I think that's kind of a just upsetting statement. I think that women go in for tests as recommended by their physician. They are taking the word of their physician on what else they need. And if they have a diagnosis, a Pap test that's abnormal, that they should be able to finish the process of getting the, final diagnosis of what might be needed to correct the issue. So anyway, just my comments on the bill. Thanks.
Senator Friends.
Thank you, Mr. Chair. Thank you, Senator Mann. Worth noting is obviously is treatment that should be covered. And so I appreciate you bringing this forward, and I think it's a compelling case. I'm a little surprised it's not already covered. I hope you'll join us, Senator Mann, and members of the committee in asking the question, okay, we need this for the patient. I think that's been more than proven here. Who's going to pay for it? The state, the ratepayers. But I think you've more than met the burden that this treatment should be provided to these patients. I hope you'll join us with this discussion about, okay, by who and through what process. Thank you, Mr. Chair.
Thank you, Senator Frentz, and I would join Senator Wiklund in being mystified as what overuse of services looks like as applied to a Pap smear. Any further questions or comments from the committee? Senator Mann. Senator Latz.
Thank you, Mr. Chairman. Just wondering if this does have, well, the A2 amendment, did that include the cost defrayment language in it? As well, I haven't compared the original introduction with the A2 amendment, and if so, any idea what this would cost the Commerce Department if this were to become law, just so we can know what we're dealing with?
Senator Mann.
Thank you, Mr. Chair. No, it did not go through a 62J, Senator Latz.
And Senator Latz, there was no defrayal included in the A2. The A2 was an author's amendment. So.
No, I understand. It's just the original bill at least in the title, said requiring the Commissioner of Commerce to defray the cost. And there's no summary for the A2 amendment. So without comparing it line to line, I guess I was wondering, is there still a cost defrayment provision in the A2, as apparently there was in the original bill?
Mr. Huddle.
Thank you, Mr. Chair. Senator Latz, yes, there actually is the standard defrayal language for the Department of Commerce in the A2 that begins on line 2.4. That's at subdivision 6 on reimbursement, and then the associated appropriation begins on 2.17.
Mr. Chairman?
My mistake, Senator Latz. Mr. Senator Latz.
So then on line 2.17, there's an appropriation provision, but it just says the appropriations for an amount necessary to make payments to defray the cost. But we don't, which jurisdiction is going to pick up the budgetary cost of this bill? Does this bill go to HHS? Does this come out of a Commerce Department budget? Do we have a process in place for the appropriation? I mean, I support the mandate, but I think we ought to know what the fiscal impact might be for this chairman's budget or wherever the money is going to come from before we make a vote.
Senator Latz, yes, and well spoken. Typically, the trajectory is for us to send it to HHS because they have a budget and we typically do not. They make the judgment on whether that fits within their budget. I'm not sure this language makes that entirely clear, but that would be my intent, and that would be the typical pathway for a bill like that.
So, Mr. Chairman,
Senator Latz.
I would assume at some point then, if this is going to come out of HHS, that we're acting really on the policy here, and that the combination policy and budget decision will happen in HHS, so they'll have some numbers to work off of, or some source of funding for it when it gets considered in HHS. Is that the idea?
Senator Latz, that would be my concept, and Senator Wiklund is welcome to join in.
All right. Well, with that understanding, Mr. Chairman, I support the policy. I'm going to support the bill. But at some point, of course, there's money involved here. Someone's going to have to figure that out. Thanks.
Other comments from the committee? All those in favor of the motion, closing comments?
Thank you, Mr. Chair. I think, again, this speaks to a larger topic of women getting health care. To Senator Wiklund's point, every time we talk about health care for women, we come up with this narrative that women are insane, right? If we let them have pap smears and follow-up pap tests when they need one, they're all going to get their girlfriends together on a Thursday morning to go get paps. I mean, that's basically what the argument was, which is crazy. I don't know if you've ever had a pap, Mr. Chair, but it is not comfortable. And then to say that because this bill did not go through this insanely flawed process, then we should go ahead and just let women die then is also like a super interesting take. Thank you, Mr. Chair.
Dr. Mann, the question is on the motion of Senator Wiklund that Senate File 3716 as amended be recommended to pass and refer to the Committee on Health and Human Services. All in favor say aye. Aye. Opposed? No. Motion is adopted. Senator Mann, Senate File 2071 is in front of the committee.
Thank you, Mr. Chair. 2071 would prohibit health insurance that cover diabetes treatment from using step therapy protocols to limit or exclude coverage for prescription insulin. Insulin to a person with diabetes is like oxygen to anybody else. Any lapse in insulin treatment can lead to serious health conditions requiring emergency room care or hospitalization. And this is just the immediate consequences. Of course, the long-term consequences being heart disease, vision loss, kidney disease, and even death. A person with type 1 diabetes is not the same as another person with type 1 diabetes. Care must be tailored to each individual patient, and so it is really dangerous when an insurance company mandates what kind of treatment a patient must have, despite having a plan in place that is working and was prescribed by that patient's doctor. Patients who need insulin do not have the luxury of jumping through the hoops of insurance companies. And so, just so that we're all on the same page as to what step therapy is, it is also known as fail first, meaning that you have to try a cheaper medication, and cheaper for the insurance company, not for you necessarily, and you have to fail that medicine before you get the medicine that your doctor actually thinks that you should have. Sometimes you actually have to fail multiple medications before you get the treatment that you need. People with diabetes do not have this luxury. 1 day, less than a day of failed insulin treatment can put someone into the hospital. Happy to go on to testify, Mr. Chair.
Thank you. Mr. Matt Prokop. And Dr. Cologne, you can come forward too. Welcome to the committee. Mr. Prokop, please introduce yourself.
Yeah, good afternoon, Chair Klein and members of the Senate Commerce and Consumer Protection Committee. Thank you for the opportunity to testify today. My name is Matt Prokop, and I'm the Director of State Government Affairs for the Northwest and North Central region for the American Diabetes Association. The American Diabetes Association mission is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. We lead the fight against the deadly consequences of diabetes and advocate for those impacted by this disease. We appreciate the opportunity to voice our support today and thank Senator Mann for her leadership on this issue and her continued efforts to make insulin affordable and accessible for folks in Minnesota. Insulin treatments vary significantly for people living with diabetes. In order to most effectively treat this disease, it's critical that we ensure that patients have timely access to the most effective treatments. Step therapy requirements can lead to individuals using medications that may be ineffective or can cause adverse effects before they can access the prescribed insulin that works best for their specific condition. This bill ensures that providers and non-insurers have the final say in selecting the appropriate insulin for the patient. Diabetes is a chronic condition that requires precise management, and unnecessary delays can cause short-term emergencies or long-term effects to patients' health, including increased risk for heart disease, kidney failure, nerve damage, and blindness. We've heard stories from across the country where patients are allergic to certain insulins and are developing rashes or even going into shock and still not being able to access their insulins due to step therapy requirements. By bypassing the step therapy requirements for insulin, Minnesota can ensure that patient care is prioritized, enabling healthcare providers to prescribe the best insulin for each patient's unique needs. This shift will improve quality of life for individuals with diabetes and prevent unnecessary health risks, and ultimately improving patient outcomes and healthcare delivery in Minnesota. Minnesota has been a leader in implementing policies that help make insulin more affordable and accessible, and eliminating a step therapy protocol for insulin is another effective policy that we can help patients access the right treatment at the right time to reduce healthcare complications and be cost-effective in managing diabetes. So as reflected also in the mandate review from the Department of Commerce and the Minnesota Management and Budget, it does not estimate any fiscal impact from the provisions of this legislation. Thank you for the opportunity to provide testimony today, and we ask for your support of Senate File 2071.
Thank you, Mr. Prokop. Dr. Cologne, please introduce yourself.
Chairman Klein and members of the committee, good afternoon. My name is Eduardo Colon. I'm here to testify as a person living with diabetes in support of SF 2071. I will note that I'm also a volunteer member of the American Diabetes Association's Advocacy Committee. I developed type 1 diabetes at the age of 21. My pancreas no longer made insulin. I am currently 72 years of age. I have practiced medicine since 1979, and the management of my diabetes has required very close scrutiny and adaptation over the course of many years. My daily life prior to my recent semi-retirement has included variable schedules, unpredictable changes in activity levels, variable meal times, and times of very low activity due to administrative duties. I was taught early on that good control of my blood sugar would have a positive impact on my life, reducing the risk of complications, and by the way, saving healthcare costs. This is verified by rigorous scientific data. In order to strive for this, I have relied on close collaboration with my physicians. Over this time, I have required changes of insulin types many times, from those that last longer to those with very short onset of action and in between. Achieving stable blood sugars is an ongoing goal and challenge for me. Arbitrary determinations of which insulin will be available to me can have very serious consequences. Low blood sugars, which are life-threatening, high blood sugars with subsequent complications, or the risk of ketoacidosis, coma, immediate ICU admission. Without insulin, I would not have survived. Without insulin, I currently would not be here. With access to good care and to insulin, I have achieved a productive life and continue to strive for minimization of the potential devastating consequences of poorly managed diabetes. This issue is close and dear to my heart, as many members of my own family struggle with diabetes, including type 1 and type 2, and including my daughter, who just recently was diagnosed with type 2. One of my dear nieces is blind and has undergone 2 renal transplantations due to poor control, lack of access, and inadequate care. If I cannot fill my insulin prescription, my life is in immediate danger. If I cannot achieve good control, I can't function fully, and I'm exposed to long-term complications. I support SF 2071 to ensure that any changes in my insulin are dictated by my provider and myself based on clinical and personal needs, not by a distant reviewer without awareness of the nuances of my care or the details of my medical history. And I thank you for allowing me to speak to you.
Thank you, sir. Questions or comments from the committee? Senator Wiklund.
I'll just express my support. When I was working like 5-6 years ago on what became the Alex Smith Insulin Affordability Act, where we were trying to address emergency access to insulin for people who were experiencing the high cost of insulin. They couldn't purchase it, and they would ration it and then have very negative outcomes. And that was when I learned that some patients would go to the doctor, and then they'd find that they had to participate in some sort of change to their insulin type, even though what they were using was working well for them. And so I just think that this is a case where step therapy is not helpful for patients. They should be working with their doctors. And if they find an insulin that works well for them, they should be able to continue with that. So thank you.
Closing comments, Dr. Mann. The question is on the motion of Senator Wiklund that Senate File 2071 be recommended to pass and referred to the Committee on Health and Human Services. All in favor say aye. Aye. Opposed? No. Motion is adopted. Senator Mann, Senate File 1302 is in front of the committee.
Thank you, Mr. Chair. I do have an author's amendment, changes the effective date and prohibits quantity limits.
Senator Wiklund offers the A5. All in favor say aye. Aye. Opposed? Senator Mann.
Thank you, Mr. Chair. 1302 requires coverage for genetic testing and imaging for people determined to be at high risk for cancer. This bill is a perfect example of the perverted way that our healthcare system works. We complain that our healthcare system is too expensive, and that is partly because we do not focus on prevention and early detection. Finding cancer in its early infancy is significantly cheaper for the entire system, and obviously it is what's best for the patient. And yet these services are not covered. This bill changes that. Happy to turn it over, Mr. Chair.
Thank you, Senator Mann. Is Deandra Newsom online?
Yes. Good afternoon. Hi,
Good
everyone.
morning. Yeah, good afternoon, Ms. Newsom. We can see you, we can hear you. Go ahead and introduce yourself and proceed.
Awesome. Thank you. Chair Klein and Vice Chair Seeberger, so great to see you again, and members of the committee. Thank you for the opportunity to provide testimony in support of Senate File 1302. This bill relates to coverage for genetic testing for inherited cancer gene mutations and the recommended screenings based off of the results of that testing. Again, my name is Deandra Newsom. I am the Regional Manager of State Policy and Advocacy for Susan G. Komen, the Breast Cancer Organization. We have had a leading legacy as it relates to breast cancer, representing millions of people who have been diagnosed with breast cancer. We have a 360 approach to fighting the disease on all fronts with our patients, diverse research breakthroughs, as well as improving access to quality care. What I want to dive into today on behalf of the 5,670 people in Minnesota who will be diagnosed with breast cancer and the 640 who will die from the disease in 2026 alone is genetic testing. Genetic testing can provide important information to breast cancer patients, their family members, and their medical providers. Not only do the results of genetic testing help individuals and their family members understand their inherited risk of breast cancer, but they can be a catalyst for patients to access targeted prevention and treatment strategies. And I want to stay on that really quickly as I take a deeper dive in this. More recently, we've seen that in the past, genetic testing for inherited breast cancer mutations only checked for mutations in BRCA1 and BRCA2 genes. These genes are heavily associated with breast cancer, and so if you don't currently have breast cancer, you would be considered high risk. It is common to be tested for multiple other moderate high-risk gene mutations in practice called a panel testing or a multi-gene testing. And it can be found that an estimated 83% of eligible patients that underwent multi-gene panel testing changes had their medical management, including modifications in imaging, follow-up, and chemotherapy strategy changed. Essentially, what we're trying to do is, if you currently have cancer, we want to know what are the best ways to treat you based off your genetic mutations, because your treatment could possibly kill you if the physician is not aware. And then for those who have a family history of cancer, they would be considered as high risk, and we would want to make sure that they're aware of that for possible prevention. According to your 62J from the Minnesota Department of Commerce, we've been touting this document across the country and supporting our genetic testing legislation. We found that you have the lowest that we've seen, one of the lowest. There is no deferral cost associated with the bill. In fact, to the Minnesota Management Budget Health Plan administrators, it was estimated that an average state fiscal impact for this particular legislation would be roughly 59 cents per member per month. And that has been really groundbreaking for us to find and learn in the state of Minnesota. As well as that, respondents confirmed that some commercial insurers in Minnesota already cover most genetic testing, as mentioned by the insurers that spoke a little earlier, and imaging services for cancer. But this coverage is subject to a specific criteria, cost sharing and prior authorization requirements. And it was an estimated cost increase of less than $1.35 per member per month. We found this to be really incredible in the state of Minnesota and see this as a nonsense type bill, and getting rid of the cost share for genetic testing. We also found in your 62J that there is a potential for downstream savings associated with this legislation. A no cost sharing for genetic testing and imaging may lead to early detection, as mentioned before, and therefore personalized screening and treatment plans. It also in the 62J, we found that since cost may be one of the primary barriers of interventions for cancer risk, this proposed coverage may also have an impact on total health expenditures associated with late-stage diagnosis, which would be really huge for the state. And it has been estimated by the Minnesota Department of Commerce that the direct savings attributed to early diagnosis can have an estimated impact of $10.7 billion nationwide across all cancer types, and cost savings in the form of decreased work absence, short-term disability, and long-term disability. By eliminating the cost barrier for genetic testing and evidence-based screening, all patients will have access to critical information regarding their lifetime cancer risk and ensure that they have access to medically recommended early detection and cancer surveillance. As committed partners in this fight against breast cancer, we know how deeply important it is for all cancer patients to have fair and equitable access to genetic testing services that may save their lives and also decrease costs. As such, we support Senate File 1302, and we urge you to pass this critical legislation. Thank you so much for your consideration, and thank you so much, Senator Mann, for bringing this bill back.
Thank you for your testimony. Questions from the committee? Senator Deems.
Well, thank you, Mr. Chair. And I'm wondering if the testifier could get me a copy of the reports that she's got from MNB and from the Department of Commerce with the facts and stuff that she was reporting.
Senator Deems, are you talking about the 62J report, or?
No, I'm talking about the testifier had talked about some numbers that she had gotten from MNB on some stuff and some numbers she had gotten from the Department of Commerce on cost and things like that and the benefits. I'm wondering if she could get me a copy of those reports.
Ms. Newsom.
Thank you so much, Senator. Though the documents the facts that I was quoting was directly from the 62J analysis.
Okay, thank you.
Thank you.
Other questions or comments from the committee? Question is on the motion of Senator Wiklund that Senate File 1302 as amended be recommended to pass and referred to the Committee on Health and Human Services. All in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, your last one. Senate File 970 is in front of the committee.
Thank you, Mr. Chair. There is an author's amendment that updates the effective date and fixed date.
Senator Wiklund offers the A5 as an author's amendment. All in favor say aye. Aye. Opposed? Senator Mann.
Thank you, Mr. Chair. 970 would require coverage for bowel and bladder care as needed after a spinal cord injury. Life with bowel and bladder issues after a spinal cord injury involves managing a neurogenic system, which means losing voluntary control and sensation and requiring very strict daily routines. It involves time-consuming scheduled care to prevent accidents, constipation, and serious complications like autonomic dysreflexia, which is an emergency condition, often impacting mental health, social health, and independence. What we have run into is that this care is very specialized. Each person is very different in what they need, and many times an insurance company will only cover what they think is appropriate, again, not knowing anything about the patient, or they cover nothing at all. In fact, this bill was first brought forward by Senator Dietzig when she was undergoing her cancer treatment. She asked her doctor, "What is the service that you most often see denied?" And her doctor replied, "Bowel and bladder cares." I have seen patients reuse catheters and end up in the ICU with life-threatening infections. I have seen patients in the ER with life-threatening reactions due to inability to properly care for this medical condition. Making sure that patients can take care of themselves before ending up in the ER or in the hospital is not only the fiscally responsible thing to do, it is the overall just right thing to do. Again, one more way that our healthcare system fails us is we can cover these services to prevent further morbidity and save the overall healthcare system money, and yet we do not.
Thank you, Senator Mann, and I don't think you have any testifiers. I'll go to questions from the committee. Senator Prince.
Thank you, Mr. Chair. Thank you, Senator Mann. Your role as a physician, your spot as a state senator puts you in a unique spot to advise the Commerce Committee and sort of tell us what you think. I have no problem with your don't ask just what it costs, ask what it pays analysis of this bill. You have my full support. But I'd like to just ask on the record, we have two sources of payment in our system, our current system, which I think you know better than most. People who buy insurance and pay premiums and taxpayers. Do you have a preference? Do you want to offer your opinion about what system would be best for our state and our country? Those seem to me to be the sources of payment for all these treatments. I see the chair nodding his head. That means my question's not stupid. And would you be comfortable, Senator Mann, just putting on the record, like what form of payment, where's the money do you think best coming from, the taxpayer or the premium payers? I have both in my district, just like you do.
Senator Mann.
Mr. Chair, that's a great question. And I think at the end of the day, the money comes from the same place. It comes from Minnesota taxpayers, whether it's coming from the general fund or it's coming when they pay their premiums. And so what we're debating here is government, I mean, from the amendment, that amendment earlier in the bill you guys passed last year, you're asking government to pay for health care, which I think is great. But then when we say, hey, why don't we take out the insurance companies and the PBMs and all the people who are benefiting off the system and not providing any care and still have the government pay for it, then people say no, which is weird to me because you're okay. People are okay with when the government pays for health care only if insurance companies extract money from it and patients don't get care. But if we say let the government pay and go directly to the patient, people have a problem with that. So I don't quite understand that argument. Again, at the end of the day, either plan will come from the taxpayer. And our job would be to remove the barriers for them to get care and remove the people who have inserted themselves into the system, who provide zero care and who extract money from the backs of sick people to make them sicker. So that's what I think should happen.
Senator Frentz.
Thank you, Mr. Chair. Thank you, Senator Mann. You know, as you can imagine, we hear from both. I know you do too in your district. Ratepayers, people who are on private insurance, farmers in my district, and I honestly hear about an equal amount. Why can't the cost be lower? And I think I hear your answer, which is the system's inefficient, spending less dollars on the patient than it should and more on some people that you find. I'm fine with that answer, and I do encourage you to continue to bring that voice. We've got all kinds of people in the Senate. Some are physicians, and if it's a health care and cost question, I think uniquely qualified, so appreciate it. Thanks, Mr. Chair.
Senator Dames.
Well, thank you, Mr. Chair. And I guess we're going to turn this into a single payer discussion today, and if that's what we want to do, we sure can have it. Senator Mann, I understand where you're coming from, and I've known that for quite some time, but personally, I don't think that the government has the ability to run things near as efficient as independent insurance companies do. And so I think that we're going to be in a real surprise like we have with so many things that we've decided the government can do it better. And at the end of the day, that's not the case. So I think we need to take the single payer discussion a lot further than where it is right now. So thank you, Mr. Chair.
Question is on the motion of Senator Wiklund that Senate File 970 as amended be recommended to pass, referred to the Committee on Health and Human Services. All in favor say aye. Aye. Opposed? Motion is adopted. Thank you, Senator Mann. The last mandate day. Senator Oumou Verbeten. Welcome to the committee, Senator. Senate File 3768 is in front of us.
Thank you, Mr. Chair. Thanks for having me today. Senate File 3768 will require all state-regulated health plans to cover the cost of doula services. Medical assistance in MinnesotaCare already covers these services. This would expand that coverage to those covered by private health plans. In Minnesota, we are facing a maternal health crisis. The most recent maternal mortality report from the Minnesota Department of Health shows that the maternal death rate for Black parents is 2.3 times higher than the state average. For American Indian parents, it is a stunning 12 times higher. It also found that 95% of maternal deaths in our state were preventable. And there were a number of recommendations in that report, but today I want to focus on one of them, which reads, policymakers should increase funding for and access to maternal health programs, including the integration of doulas and postpartum support services into healthcare coverage. So doulas provide support during pregnancy, birth, after a baby is born. They don't replace the care of midwives or doctors. They really supplement, provide emotional, physical, educational support to pregnant people and their families. They are advocates. They help people reach specific goals during their birth. Research has demonstrated the value of doulas. In 2014, the American College of Obstetricians and Gynecologists noted that published data indicate that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel such as a doula. There are a lot of other benefits that you may hear from other testifiers today. I do want to note that in this bill, the definition of certified doula is something that's already in statute because of the coverage that already exists. So I want to just share a little bit more about my personal experience and why I know doulas are so important and everyone deserves that coverage. I became a mom last year. I have my little one with me today who's still taking a nap, hoping he makes it through this hearing. And I really can't imagine having gone through that without the support of my doulas. I'm, here to be able to tell this story, but when we think about the report that I referenced earlier, see, now he wants to chime in. I experienced a pretty terrifying breakdown in care that I know has cost other parents their lives. During my birth, I was repeatedly dismissed by a provider who ended up reading the medical history of a completely different patient. I ended up needing an urgent C-section. After I consented, the team at the hospital went silent for hours. It was really scary, and throughout my labor, I experienced violations of my autonomy, a complete disregard for my safety and my child's safety. But thankfully, I had doulas present. My doulas, Ade and Abiola, who are here today from the Maye Collective, were really my only consistent advocates throughout my labor. They were supportive even before labor started. In the kind of late stages of my pregnancy, they were there 24/7 for questions that I had. They helped me develop a birth plan. They, of course, were there throughout the entire labor. When we got to the hospital and I was stuck in triage, waiting in pain and waiting for a room in the hospital, they were there and responded. I had asked for a birthing ball. No one had gotten back to us. They just went ahead and found it in the unit for me. Obviously, when you're in labor, it's really, really hard to communicate, being in that level of pain. They were able to advocate on my behalf. They were able to have conversations with my providers so that I could focus on my labor and my husband could focus on supporting me in that moment. They intervened when I was dismissed, and we had to force a provider to check my medical chart and realize they were confusing me for another patient. And when no one was responding to us as we were waiting for that surgery, they went and tracked folks down. So, as difficult as it was to experience all of that, I also want to make sure I point out the really joyful parts of my labor that they were also responsible for, particularly the early stages at home. They were there for all of it, timing contractions, telling us when it was time to head to the hospital, capturing some really beautiful moments for us, photos and videos that I have of the first moments that I met my child that I'll be able to cherish forever. They, of course, checked in on me and my husband and my baby once we gave birth. And once I had time to kind of process everything that happened, they were able to support us through the process of filing a complaint as well with the hospital. So all that to say, at a minimum, they were really crucial in protecting the joyful parts of my labor, and they were advocates who I think saved my life. So last summer, as I was getting ready to give birth and first reached out to the Maye Collective, so when I learned about the fact that not all insurance is covering these services, it can be a lot of money for families to make that investment. I know we had to talk that over, and we just didn't want to have any regrets about doing everything we could to ensure my safety and the safety of our child. That's when I decided to work on this bill, realizing that those who aren't on medical assistance or MinnesotaCare, who can't afford to pay for this out of pocket, are really the folks that I think we need to pay attention to with this bill, especially knowing that the disparities that do exist, really, we see them across socioeconomic status, especially for Black parents and American Indian parents. So in compliance with the 62J, notified the Commerce Chair, the HHS chairs by the August 1st deadline, and requested that the Department of Commerce evaluate this proposal. I do also want to mention that there's an argument to say doula services actually fall under Minnesota's essential health benefits benchmark plan, which does specifically include maternity and newborn care. I think this is absolutely a part of maternity and newborn care. I'll just conclude by saying I think every birthing person deserves to have an advocate on their side. We really can't continue to let this be a luxury for those who can pay out of pocket or just be a benefit for our public plans. And if we want to move the needle on those 95% of preventable deaths, we need to fund the advocates that keep us safe.
Thank you so much, Senator Oumou Verbeten. And is Susan Abdallah Lane present? Welcome to the committee. Please introduce yourself when you're ready and go ahead.
Mr. Chair and members of the committee, Senator Verbeten. My name is Susan Lane, and I'm a doula and childbirth educator for over 30 years. I've attended more than 350 births during that time, and I'm also a board member of Everyday Miracles, which is a nonprofit that provides culturally congruous care, doula care, to Medicaid recipients. I've been a citizen advocate here at the legislature since 2003, which was the first time we came with this particular bill. So I thank you for this opportunity. Much has happened since then. Some others are going to talk to you about the specific benefits of doula care. I would emphasize that this is preventive care. It is not treatment, it's preventive. And I would also emphasize that the research and support of the reduced cesarean rates and many other benefits of doula care has been rated by the American College of Gynecologists and Obstetricians as among the highest level of research, the highest quality of research. So among like 33 different types of preventive care, only 4 got an A rating for the quality of the research in support of the care, and doula care was one of those. So there's research and there's research, as you all know. And this has been some of the best over the years, which is why I believe doula care was granted Medicaid coverage. I would like to just add that since I first came here all those years ago, decades ago, a lot of changes have happened. Components of doula care have become part of standard hospital care. For example, doulas were the first people to bring a birthing tub into a hospital. We literally carried the portable tub into the hospital and set it up. Now, most metropolitan hospitals in their redesign and upgrading have included very expensive and fancy birthing tubs based on that experience. We also brought in the first therapy balls, literally, again, carrying them in ourselves. Now, in every metropolitan hospital, as you've heard, there is a variety of sizes and shapes of therapy balls that are used in labor. And in addition to that, many of the techniques that we use that ease and shorten labor for mothers and babies have been adopted by nurses. In fact, hundreds of nurses have been trained in these techniques, which were developed by doulas. So we've had a major impact, and one of the results of that is not only the Medicaid payment, but there are a few companies that are providing insurance right now. CVS and Best Buy offer one of their plans to some of their employees, which covers doula care. And Blue Cross and United and TRICARE have begun offering a plan. But the problem that we've run into is that our private pay clients have been waiting for months, oftentimes, to get approval for their doula care. And you need to have that approval in advance before you can hire your doula. So we right now at Everyday have some private clients we're billing for who've been waiting for over 2 months. Their babies may be born before they have approval to hire a doula, and they will not be able to afford that doula if the care does not come through, which they understand is offered to them through their plan. So it's been very haphazard. It's coming, but it is not clear. It is not consistent. And so we really feel that this needs to be something that can be offered to all clients. I'd also add that to make a living as a doula, which I have not needed to do, doulas have to have private clients as well as Medicaid clients. There has to be a body of people out there that can pay for this service. And right now that doesn't exist. Most of my clients are upper middle class clients and they can pay for it. But I get calls all the time, and I do offer a sliding scale from people who cannot. And we all know that the economics are such that it makes it much more difficult for communities of color to be able to afford the private source, even working families, to be able to pay for private doulas. So I think this is basic preventive care, which is somehow inaccessible to the majority of birthing women in our state. For me, this is paramount to denying payment for mammograms or any other type of basic preventive care. So
Thank you, Ms. Lane.
I would thank you for the time today.
Appreciate you. Questions from the committee? Senator Dames.
Well, thank you, Mr. Chair and Senator Oumou Verbeten. Did you have this go through the J62 research with the Department of Commerce?
Senator Oumou Verbeten.
Thank you, Mr. Chair, and thank you for the question. Yes, I submitted this through the 62J process to the Commerce and HHS chairs by the August 1st deadline. I would defer to the Department of Commerce on any further questions about that, but followed the process to evaluate the proposal.
Follow up, Mr. Chair.
Senator Dames.
Did you receive the report? Has it been completed?
I can take that one, Senator Dames. The 62J was not selected. In previous years, we've had the option of 10 62J reviews, and this year, at the last minute, the number was drastically reduced. We had already decided to discuss this essential health care benefit, and we did give it a hearing here in the Commerce Committee today, but it was not selected or able to be completed by the 62J process.
So will it be resubmitted next year then?
Yes.
Thank you.
Senator Seeberger.
Thank you, Mr. Chair. Your testifier mentioned the year 2003. That's the year I became a mother. And I also used a doula for the births of both of my boys. They were not home births, they were water births. And they were, I was ahead of my time. I mean, it wasn't common in 2003. I wore my babies just like the senator is doing now, which also wasn't common. You couldn't buy the baby wraps, I made them. So this issue speaks to me personally. The doula that I used was phenomenal. I used her for both of my births. However, as valuable as the services are and as grateful that I am that they're recognized by under MA and are being utilized further, I cannot go so far as to mandate coverage by private insurance companies to cover these services. So unfortunately, I will be a no on this, but I do recognize the value of doula services.
Further questions or comments from the committee? Closing comments from Senator Oumou Verbeten.
Thank you, Mr. Chair. If it's okay, I'd like to just defer my kind of closing comments here to one of my doulas, Ade Salami, who I don't know if was on the list. That might have been my bad, but if I can defer to her on closing comments, that would be great.
You bet. I don't have your name, ma'am. Please introduce yourself and proceed.
Good afternoon, Chair and committee members. My name is Ade Salami. I am a prenatal and postpartum doula alongside my sister, Dr. Abiola Boubacar, and we are the founders of a BA Collective, the doula services company that we've owned for over 6 years. At a BA Collective, we focus on the well-being and happiness of the birthing person and the family during pregnancy, during childbirth, and also their postpartum experience. We want to empower them to build a community that reflects their values, as well as the ones that they want to share with their child. Expanding the coverage of doulas to include families that are having children under the coverage of all health plans is necessary to support the well-being of all pregnant people in Minnesota. And I think that from my sister and I's collective experiences in policy and in healthcare, something that we have experienced as well as our time as doulas is we can't overstate the importance that this would have on the lives of everyday Minnesotans across the state, like from here in the metro up to Red Lake and everywhere else in between. The way that things currently stand, healthcare plans in the state of Minnesota provide perinatal and postpartum doula coverage and reimbursement as a benefit to those who are birthing on Medicaid, because the state understands that the significant benefits that a doula care can offer a pregnant person is important. And so reduced cesarean sections are a benefit of that, improved length of labor, increased understanding of medical interventions, and informed decision-making, as well as engagement in their postpartum care. There's also a reduction in anxiety and stress related to labor and the postpartum period, and there's improved breastfeeding success for new mothers. And they also are more likely to continue breastfeeding well into their child's first year of life. So the existence of the current law that we have for Medicaid reimbursement takes the guesswork out of what is needed to make doula coverage for all in the state a reality. And so the state already has clearly defined what a doula is, as well as what their services entail. The state has already authorized organizations that are permitted to train and certify doulas who wish to have their services covered by health plans in the state of Minnesota. And lastly, the state has already provided a clear list of services that are deemed as reimbursable to health plans per state law. So some would argue that the only work left to do for doulas here is to hold Minnesota health plans accountable for paying timely payments to doulas that are supporting Medicaid customers, but that's not happening. And more importantly, for the 38,000 families in 2024 who gave birth without a doula coverage, they do deserve more from us. Many of them have been sidelined from experiencing the positive impact of what a doula can do because of their inability to pay. Access to doula care and during the prenatal and postpartum period supports parents in ways that our existing systems and healthcare plans don't have or simply don't offer. And I think that during the winter of 2024, something I'd like to share in a story here is that our company supported an insured client who did not have doula coverage, but she went into spontaneous labor and gave birth to her fourth child. We do often for insured clients that don't have coverage for doula reimbursement, we did offer her a discounted rate because she did want a doula, and one of our foundational beliefs as an organization is everyone deserves one, so we try not to let cost be a factor. Hours after she was discharged, she called us to let us know that she was feeling pain and pressure that was inconsistent with her previous births. And a couple of days after that, and as well as of constant temperature checks, we had discussions about the sensations she was feeling, and she sent us a photo of something that she found hanging outside of her, and it was actually a piece of her placenta that was not removed during her delivery. So when she went back to the hospital armed with that information, they finally provided her, without actually considering her own bodily expertise, the instruction that she should have come back, and they didn't also take into consideration that they put her at risk of the fact that since they had not fully removed her placenta, that she was in the early stages of sepsis. So she was able to receive treatment for the early stages of that infection, but she could have reached full-fledged sepsis had she not known or communicated that she was experiencing those things. And the hard part about what she had shared when she shared this information was that the care team that she had had prior to discharge was aware of this. She shared that she was experiencing those symptoms, and they assured her that she didn't remember what her postpartum pain felt like, and that she also told those same members of her care team that when she went in 2 days later for her child's first checkup, she was experiencing those symptoms. And again, they told her that she was fine, but if the feeling persisted in a couple of weeks, she should bring it up at her next visit. And so again, just to offer here that the doulas are not the only solution for a broken maternal health system, but they are an evidence-based solution, and it's something that I hope that you consider.
Thank you, ma'am, and thank you, Senator. Senate File 3768 is laid over. Senator Wiklund. Welcome to the committee, Senator Wiklund. You have an A6 author's amendment. Senator Wiklund offers the A6. All in favor say aye. Aye. Opposed? A6 is adopted. Senator.
Thank you. Thank you, Mr. Chair, and I appreciate having the hearing on Senate File 1101, which would be coverage requirements for augmentative and alternative communication devices. The A6 amendment What it does is, well, it updates dates, but then it also narrows or focuses the bill in a way that we were hearing feedback that perhaps it was overly broad and harder to discern what coverage was going to be required. So what it adds is that we're mirroring the requirements for individual market coverage with the Minnesota Healthcare Program's coverage. So what Medicaid cover or medical assistance coverage. So hopefully that helps people who are looking at the bill to understand better what we're trying to achieve with this bill. I just will say briefly, the augmentative and alternative communication devices, the importance of these devices was brought forward to me by a constituent. And these devices are ways to help people who have trouble speaking to communicate. Users include children and adults. And coverage matters because I think it can be easily shown that being able to communicate effectively from the most basic needs you have is really essential for every person. It's essential for safety and health, and it supports, obviously, independence. And then in terms of benefits for health, it prevents worse outcomes from happening if people can communicate. And what I'd like to do is turn it over to my testifiers so they can tell more about, why this is such a needed coverage.
You bet. Thank you, Senator Wiklund. Members, we're going to remove the Klein bill from the agenda since we're running short on time. But I do want to get to the Maye Quade bill. So if the testifiers, we have 3 of them, if you could confine yourselves to 2 or 3 minutes. And we'll start with Joe Carr, if you're online. Mr. Carr, are you with us?
Hello, Senate Commerce Committee. My name is Joe Carr. I have been using various augmentative and alternative communication devices since I've been in pre-K and I am now 22 years old. These devices have helped me communicate with family, friends, school peers and staff, and in the community. My speech can be hard to understand sometimes as I have cerebral palsy. I use my device when I go shopping, hanging out with family, during meetings, Zoom calls, doctor appointments, phone calls, volunteering, and sporting events. Sometimes in loud environments it's hard to communicate when you have cerebral palsy. Having a device in loud environments helps me project my voice so that I am easily understood. Over the years, I have used simple devices that just had a few words on. During my elementary school years I used a Dynavox, and now I use my iPad with a communication app to communicate. My hope would be that all commercial health plans would cover these augmentative and alternative communication devices. Thank you, Senator Wiklund, for authoring this important bill. Thank you for your time.
Thank you, Mr. Carr. Ms. Dana Indovino-Cawley. Welcome to the committee. Please introduce yourself and proceed.
Hi, thank you. I'm setting a timer for myself. Hello, Chair and members of the committee. My name is Danny Indovino-Cawley, and I serve as the Policy Committee Co-Chair for the Minnesota Consortium for Citizens with Disabilities, as well as being a self-advocate and a parent advocate. I'm here to speak in support of SF 1101. Augmentative and alternative communication devices, or AACs, give people a voice. If someone has receptive language, the ability to understand language, but cannot produce speech, an AAC can help them communicate. These devices can be as complex as speech-generating tablet or as simple as a laminated board with pictures, and in many ways they are to expressive language what a hearing aid would be to receptive language. Yet despite their importance, AAC devices are almost always excluded from private insurance policies. My son was diagnosed with autism at 4 years old, and at the time he had fewer than 50 words to communicate his needs, which led to frequent meltdowns and a very frustrated child. It strained our relationship, and as a parent, I felt like I was failing him. His speech therapist recommended an AAC device. It could give him ways to express himself and to have a voice. But our insurance denied the request outright. They told me regardless of medical need, our policy specifically excluded AAC devices. Insurance will pay for years and years of therapy to teach a child to speak, but not for the device that could give them a voice today. While AAC devices can be expensive upfront, they're an investment that pays lifelong dividends. When someone can communicate, they can answer medical questions accurately, reducing unnecessary tests and scans. They may need less intensive special education support, and they're also less likely to be misdiagnosed. Right now, the only reliable way to get an AAC device covered by insurance in Minnesota is through medical assistance. That means many families enroll in state healthcare system to access a communication device their private insurance will not cover, that might not have accessed that system otherwise. In the end, my son learned to speak without a device and was able to finally tell me that he loved me. But every day in Minnesota, someone has a stroke, suffers a traumatic brain injury, receives an ALS diagnosis, or learns they are autistic. They're told technology exists that could help them communicate, but accessing it means paying an enormous cost or waiting months for disability benefits. Minnesota already recognizes the importance of communication. If you have insurance, hearing aids are covered because of a mandate that was passed. Communication should not depend on what insurance you carry. So I urge you to support this bill so that everyone, whether they have private or public insurance, has timely access to an AAC device, because everyone deserves the ability to tell their mom, I love you. Thank you for your time.
Thank you for your testimony. Is Jillian Nelson present? Welcome to the committee. Please introduce yourself and proceed.
Good afternoon, Chair Klein and committee members. I am Jillian Nelson, Policy Director for the Autism Society of Minnesota, also a self-advocate and also a parent advocate. Thank you for taking the time today to hear Senate File 1101. I will keep my remarks brief. This bill is about giving people access to communication. Communication is a fundamental part of being human. What we know is that without access to meaningful communication, such as an AAC device, communication does not cease, but it does get more complicated, and the repercussions from not understanding become much more costly. For example, an autistic kiddo without functional communication has to use behavior to communicate about literally everything. From a verbal 4-year-old, we often hear words like, I'm scared. But when a kiddo can't say that, it comes out in behavior. It may look like aggression or elopement or many other things. And all too often, the instinct is to treat the behavior medically, through medication or hospitalization or more. And these things cost insurance companies astronomical amounts and often end up in parents applying for TEFRA Medicaid in order to afford the expenses, when this could have easily been solved with access to communication through AAC. I am scared. Those words are a parent's cue to comfort. I can only imagine the trauma caused when fear is met with behaviorism rather than comfort. That example is actually the best outcome of not having functional communication. I want to share a little bit with you about my cousin and my nephew. My nephew lived with cerebral palsy caused by an interrupted SIDS incident. He was non-speaking. At 14 years old, we lost him. His insurance wouldn't pay for AAC, so his communication was limited to yes or no buttons, which required someone to know the right questions to ask. Unfortunately, the questions asked when he was sick did not lead to an accurate diagnosis, and he died just days before his 15th birthday. My cousin lived in Texas with classic autism. He never spoke. He was denied AAC by his insurance company 17 times. His parents didn't qualify for Medicaid in their state. My cousin died of a blood clot after breaking his leg. He broke his leg in a moment of distress when he could not tell us what was wrong. And then later, he died from the blood clot caused when he couldn't tell us he felt something strange in his body. His death would have been presentable with an AAC device. Communicating is a core function of being human. We should not balance the merit of whether or not access is deserved based on a financial impact to insurance companies. Please make sure that no more lives are lost and no more trauma is caused. Thank you for supporting Senate File 1101.
Thank you, Ms. Nelson. Questions from the committee? Senator Wiklund.
Oh, thank you, Mr. Chair. I think the statements by the testifiers really conveyed what I would want to convey. I will add that I did hear from speech language pathologists who work in schools, and many of them wrote that they were found it very challenging that they would be able to offer access to a device in a school setting, and they could see the progress that a student would make having access to the device, but then the child would have to go home and they couldn't take it home with them. And so I just think that this is really unevenness and unfairness in coverage that is really preventing kids from leading their fullest lives and leading healthy lives. And this is a coverage that we should require. So thank you. And I also just say I was really happy to be able to present today with two constituents. The one, Danny, brought the bill idea forward to me, and I really appreciate that. And Joe is also a constituent of mine who lives in Richfield, so thank you.
Wonderful. The question is on the motion of Senator Wiklund that Senate File 1101 as amended be recommended pass and referred to the Committee on Health and Human Services. All in favor? Aye.
Aye.
Aye. Opposed? Nay. My apologies for the early gavel. The motion passes. Senator Maye Quade. Senator Maye Quade, you can close us out with Senate File 1961, which is in front of us. You have an A5 authors amendment. Senator Seeberger offers the A5. All in favor say aye. Aye. Opposed? Motion is adopted. Senator Maye Quade.
Thank you, Mr. Chair. Members, thank you so much for agreeing to hear Senate File 1961, the Minnesota Building Families Act. The Minnesota Building Families Act is a simple bill with an inarticulable impact. It would require insurance to cover the cost of infertility treatments. So many Minnesotans are waiting and excited to start or grow their families, but cannot because their health insurance doesn't cover the cost of the diagnosis and treatment of infertility. Families cash out their 401ks, take out second mortgages on their homes, max out credit cards, take out loans, even have bake sales just to have a child. Extreme financial stress is not the way any family should be welcoming their child into the world. The Minnesota Building Families Act would lower cost sharing and provide access to infertility diagnosis and treatment for the 1 in 7 couples dealing with infertility in Minnesota. For the last 3 years, I've had Minnesotans from across the state call, email, stop by my office, begging for one thing: please pass this bill. I'm so proud that this bill is bipartisan, and for all of the bipartisan work that has gone into it. I want to thank my Republican colleagues, including Senator Duckworth, who is on this committee, who have co-authored this bill with me. We may not agree on every issue, but we agree that Minnesotans who want to start their families should be able to. Requiring insurance to cover a medical diagnosis and treatment of infertility is not only the logical thing to do, it's the right thing to do. I urge the committee to support this bill today, and with it, the couples and individuals across Minnesota, my family included, who need these services. If we want Minnesota to be the best state to raise a child, we have to be the best state to start a child. Thank you.
Thank you, Senator Maye Quade. Maye Quade, please introduce yourself and proceed.
Thank you, Chair Klein and committee members. My name is Maye Quade, and I am here as a patient advocate and the president of the Minnesota Building Families Association, which educates and advocates for access to fertility care in Minnesota. Before I begin, I'd like to propose some hypothetical questions to the committee. For those of you who are parents, how much of your financial future would you risk for your child? And for those of you who dream of becoming parents, how much of your financial future would you risk to make that dream a reality? Now I want you to imagine yourself sitting at your kitchen table, surrounded by medical bills. Your heart is heavy, and every day you wonder how you will make your ends meet. You ask yourself, how much more can I sacrifice? At what point would I be forced to give up? And in that moment, Giving up would mean the devastating reality of never getting the chance to meet the child you've dreamed of, the child you have fought for. This isn't hypothetical for many Minnesotans. It's reality. In Minnesota, 1 in 6 people experience infertility. More than 186,000 people. Half of them are men, half of them are women. Nearly 10% of cancer patients, about 8,000 Minnesotans, may need fertility preservation to build a family. My own infertility story includes 7 miscarriages, 2 rounds of IVF, and the crushing financial burden of paying out of pocket because my insurance didn't cover fertility treatment. My husband and I took out a second mortgage, accessed retirement funds, and our family hosted a fundraiser to bring my daughter into this world. She turned 5 this week, and she made sure to tell me that I better let everybody know she's 5, not 4. We still have 2 embryos left, but without insurance coverage, we can't afford to add to our family. Every day I live knowing the family I dream of could be mine if only I had insurance coverage. My story is not unique. Without fertility insurance, families drain savings, max out credit cards, and take out second mortgages, all for the chance to dream of parenthood. But there's hope. Senate File 1961 offers the solution. Studies show that when insurance covers IVF, health outcomes improve for mothers and babies. Healthcare costs go down. In the 25 other states across this country that have passed fertility coverage laws, there has been little impact on insurance premiums. A 2021 Mercer study of over 450 employers found 90% of employers offering fertility care coverage, including IVF, saw no significant increase in medical costs. Fertility coverage doesn't just save families financially, it saves lives too. Patients in states with fertility insurance see less risks due to multiple births and the need for costly NICU care. Fertility treatment is healthcare, not a luxury. A recent study by the Women's Health Research and Action Center shows 65% of Americans support mandated insurance coverage for fertility treatment. Even state employees and legislators, such as yourself here today, have fertility insurance coverage. The families you represent deserve the same access. Without fertility insurance, families pay out-of-pocket costs for that, for the insurers, but insurers get to negotiate at lower rates. The burden falls entirely on families, not insurers who benefit. Today we stand united, patients, providers, and employees, many of whom are behind me here today wearing orange, demanding action. This bill is pro-family, bipartisan, and ready to pass. So I asked a question earlier. How much would you risk to make your dream of parenthood a reality? Perhaps your children or grandchildren will face that same question one day. Senate File 1961 gives you the chance to act now, so they never have to ask, how much of my financial future can I risk to become a parent? Please pass Senate File 1961 and give Minnesota families a reprieve they desperately need. Thank you.
Thank you, Ms. Grahn. Dr. Khan, please introduce yourself and proceed.
Thank you. Dear Chair Klein and committee members, thank you so much for this opportunity to testify in front of you today. My name is Zarak Khan, and I'm a professor of OBGYN and chair of the Division of Reproductive Endocrinology and Infertility at the Mayo Clinic. But I'm also sitting here in front of you because I wouldn't be here had my parents not had access to fertility coverage in the UK almost 40-some years ago. I won't give you my age yet. It is likely that everyone in this room knows at least one soul that has had or continues to struggle with infertility. Infertility affects 1 in 6 individuals globally and 1 in 7 in Minnesota. Yet too many Minnesotans pay monthly insurance premiums for plans that will cover neither the diagnosis nor the standard treatment of this disease. And yes, I say it is a disease defined by the WHO and not a luxury treatment. Even though, more importantly, the insurance plan will not cover costs for cancer patients to preserve their ability to have future children, young patients, when diagnosed with cancer, have a very short window of freezing egg and sperm, and we really need to act in those scenarios as well. Really, most of the patients that I see don't require IVF or advanced fertility treatments, but my patients are mortified to step foot into my clinic due to the cost associated with that. It is these delays that I fight against every single day, these delays that destroy my patients' dreams of family building, and these delays that will ultimately increase their cost of invasive treatments if their treatment is delayed. Conversely, when IVF is needed, outcomes are better when people have insurance coverage. Simply put, insured patients really resort to single embryo transfers, and this lowers multiple births, which generates huge cost for insurance companies and leads to healthier moms and babies. Again, our mantra, healthy moms and babies. Without requiring insurance coverage, the ability to build a family depends on the ability to pay, and I witness this inequity every single day of my work. My colleagues that have insurance coverage around the country for their patients really get to treat medicine and do medicine in order to serve the patient's need rather than be dictated by insurance coverage or mandates. And that is something I would really want for my patients as well. The ability to treat a disease should not depend on where you live or are stationed at. It is time now to pass the bill. For those struggling with infertility or facing a cancer diagnosis, further delays would mean even more Minnesotans not realizing their dreams of parenthood. Thank you very much.
Thank you, Doctor. Can Rebecca Delahunt and Maggie Hanji please come forward? Welcome to the table, Ms. Delahunt. Please introduce yourself. Proceed.
Chair Klein and members of the committee, thank you so much for having me today. My name is Rebecca Delahunt, and I work as Director of Public Policy with Minnesota Family Council. SF 1961 would mandate all health plans in Minnesota cover assisted reproduction services, including, based on our reading of Subdivision 5, most likely surrogacy contractual arrangements. The language of Subdivision 5 requires that health plans must not limit, quote, any fertility services based on an enrollee's participation in fertility services provided by or to a third party. The process of surrogacy is complex. Eggs and sperm are sourced either from the person or people who will raise the child, called the intended parents, IPs, or they can be purchased from a seller, otherwise called a donor. Eggs and sperm are fertilized into multiple embryonic lives and often graded by quality, viability, and other characteristics. The surrogate, or so-called gestational carrier, the woman carrying the baby, will hand over the baby immediately upon delivery to the IPs. Most surrogacy arrangements are paid, meaning that the surrogate is paid for renting her body, and she must follow contractual requirements on medication, diet, lifestyle, etc. Surrogacy always involves the intentional stripping of a child from the only mother the baby has known, a serious injustice to these children. Although surrogacy agencies may require a background check of IPs, there is no federal or Minnesota law requiring a background check. Foreign nationals come to the U.S. for surrogacy arrangements. Upon birth, the child becomes a citizen under the 14th Amendment. The Journal of Fertility and Sterility reports that Chinese foreign nationals are the largest proportion of foreign intended parents in the studied period from 2014 to 2020. Relative to U.S. IPs, international IPs are more likely to be male and over 42 years old. A Wall Street Journal article in your packets from December 2025 titled, "The Chinese Billionaires Having Dozens of U.S.-Born Babies Via Surrogate," reports on Chinese foreign national males getting tens and even working toward 100 children via U.S. surrogates. Surrogacy costs vary, but after compensation, agency fees, IVF embryo creation and transfer, legal fees, and other costs, the cost can be $100,000 to $200,000. Minnesota taxpayers should not pay for the intentional creation of children to separate them from the only mother the baby has known. Surrogacy is not protected in Minnesota statute, and we argue that it should not be, but it is notable that this bill likely mandates insurance coverage of an extra statutory practice. Mandating insurance coverage of surrogacy is not good public policy for Minnesota. Please vote no on SF 1961. Thank you.
Thank you, Ms. Delahunt. Ms. Hanji, please introduce yourself and go ahead.
Thank you. Chair Klein and members of the committee, my name is Maggie Hange, and I'm the Assistant Director for Family Policy at the Minnesota Catholic Conference, the public policy voice of the Catholic Church in Minnesota. We're speaking today in opposition to SF 1961. Please vote no. Facing infertility is a devastating reality. We acknowledge the pain that couples experience and have great compassion for their circumstances, but we must recognize that children are gifts. They are not commodities to which we have an automatic right. Once we look past the emotional appeal, we face difficult ethical dilemmas. More children are killed at IVF clinics than at Planned Parenthood in a given year. Some reports say that up to 90% of embryos created are never born. Many are discarded as medical waste, donated to science, or left frozen for an indefinite amount of time. To determine which of the embryos will have the best chance at life, preimplantation genetic testing is often used. In 2020, this was used in about 50% of the time. PGT is problematic as it can lead to modern-day eugenics. We can now create designer babies with the characteristics and sex desired by their parents. This practice also comes with low success rates. Nationally, 37% of assisted reproductive technology cycles resulted in a live birth. Put the other way, 63% of all cycles fail. And the cost is staggering. Each IVF cycle costs between $15,000 and $30,000, and most couples need more than one cycle because the underlying issue causing the infertility has not been properly treated. Thus, couples can easily spend upwards of $100,000 and may never achieve a successful pregnancy. We should not be using taxpayer dollars to coerce people, including religious employers, into paying for a practice that is not good medicine or sound ethics. One of the more alarming aspects of this bill is that it would allow for taxpayer funding for commercial surrogacy. Surrogacy creates a marketplace where wombs become commodities and children become products. It exploits women and intentionally strips a child of the only mother he or she has known for 9 months. This has detrimental effects for all involved. We should certainly not be funding this practice without properly vetting it through the legislative process. When discussing infertility, it is important to remember that infertility is not the disease in and of itself. It's a symptom of an underlying condition like a hormonal imbalance, blocked fallopian tube, or endometriosis. Pushing couples towards IVF and related treatments without first treating the underlying cause of fertility is problematic. A better path forward is by promoting and covering restorative reproductive medicine, or RRM. RRM works with the woman's body to diagnose and treat the underlying health conditions that may be inhibiting the infertility. It's a tailored approach for each person based on his or her specific needs. RRM is often cheaper than IVF and more successful. To that end, we ask you to support instead SF 4166, which is carried by Senator Coleman. Couples deserve better than being funneled down the assisted reproductive path. We should not misplace our compassion by trying to play God and creating children in a lab, and in some cases, separating them from one or both biological parents. Please vote no. Thank you.
Thank you, Ms. Hange. Senator Duckworth.
Thank you, Mr. Chair. I appreciate that. I would like to offer the A6 amendment.
Senator Duckworth offers the A6 amendment. It is distributed. Senator Duckworth.
Thank you, Mr. Chair. I appreciate it, and I appreciate the complexity and differing perspectives regarding this issue. I had a conversation with the bill author regarding this amendment before. Essentially, it provides an exemption for religious reasons to organizations that would qualify to not have to be mandated to provide this coverage. We'd be happy to have Senator Maye Quade give her thoughts as well if she would like to. Thank you.
Senator Maye Quade.
Thank you, Mr. Chair, and thank you, Senator Duckworth. We did have a great conversation. I would accept this as a friendly amendment.
Further discussion on the A6. Senator Duckworth. Senator Rasmussen.
Thank you, Mr. Chair. A high compliment. I have a question for the amendment author. It's my understanding that this would cover religious exemptions, but does it cover perhaps broader moral, ethical objections that might not be tied to a specific religious organization?
Senator Duckworth.
Thank you, Mr. Chair. The way it's drafted, it specifically accounts for religious objections. Open to conversations or tweaks to language or verbiage in the future. But when I look at line 1.24, 1.23, 1.24, it says on account of religious objections.
Senator Rasmussen. Satisfied. Further discussion on the bill. Oh, we should vote on the A6. All in favor of the Duckworth Amendment A6, say aye. Aye. Opposed? It is adopted. To the bill. Senator Rasmussen.
Thank you, Mr. Chair. I just want to start off by saying I have much empathy and compassion for families experiencing infertility. One of the questions I had was for actually Dr. Khan, if you wouldn't mind coming up. Thank you, Mr. Chair, and thank you, Dr. Khan. And I just want to say, I appreciate the important work that your medical team does, the OBGYNs at Mayo Clinic, and I just want to express my gratitude. One question I had is, we've had concerns brought up here today about, surrogacy, where you might have an individual who could go to a surrogacy agency and say that they would like to get 10 girls or 20 boys, or having those types of commercial arrangements. And I just wondered, as a physician, as a medical practitioner, do you think that there is an ethical line in this line of work, where whether it's selecting on gender, whether it's on having an individual who is putting an order in with a surrogacy agency, do you see any ethical lines that we should be concerned about within this industry?
Thank you, Senator Rasmussen, for your question. And I think it's a really interesting one. A part of what we do in the reproductive medicine sort of area, every single thing has an ethical dilemma, and we have ethical advisory boards. We have our practices governed by ethical advisory boards as well. And as far as the question of sex selection comes between selecting male versus female embryos, the ASRM actually has a pretty strong statement against that. We do not perform sex selection, actually, in my practice as well. And there's some ethical guidelines and sort of committee opinions regarding the practice of that. As far as the use of gestational carriers are concerned, gestational carrier use actually is a fairly medical, straightforward answer. So we use gestational carriers in scenarios where the couple is without a uterus, or if there is a medical contraindication to pregnancy. And a medical contraindication to pregnancy really defines as the risk of mortality increased by 20% or so. So I think that as far as the work that we do is laid on sort of very strong evidence, and there is really good governing bodies that really govern that practice for us.
Senator Maye Quade.
Thank you, Mr. Chair, and I really appreciate Senator Rasmussen, your question, and Dr. Khan for kind of going down the road. But this bill actually doesn't deal with surrogacy at all. There's nothing in this bill that would cover surrogacy agreements, legal contracts, compensation to surrogates. This bill is specific to a diagnosis of infertility and treatment of that infertility for a person. And you can't have your insurance cover somebody else. And by definition, surrogates are not infertile. And so their own insurance would actually not cover it. So I understand that it's a heated topic. I totally get that. I had a bill to put regulations into law around surrogacy contracts in the state of Minnesota last session. Happy to talk about that with anybody at any time, but this bill really isn't about that.
Senator Rasmussen.
Thank you, Mr. Chair. And my reading of the bill is different than the bill authors. And I would just point members to a few pages in the bill. First, on page 2, line 3, one of the criteria in terms of a definition of infertility can be a person's inability to reproduce without medical intervention, either as a single individual or with the person's partner. And to me, Mr. Chair, that's clearly pointing towards commercial surrogacy. Also, Mr. Chair, if we look on page 3, line 7, any fertility services based on an enrollee's participation in fertility services provided by a third party. That is listed as something that cannot be excluded by a health insurance plan. To me, Mr. Chair, that's very clearly covering commercial surrogacy. And when you look at a letter included in our packets from the Center of Bioethics and Cultural Network, they also very clearly state that the lines 2.3 and 2.4 would expand how we've traditionally thought of infertility as a disease to looking at commercial surrogacy and potentially covering those arrangements. And so the bill language, some of the testimony provided me today, has me concerned that this bill would, in fact, require health insurance companies, would require taxpayers to cover commercial surrogacy. And I have a lot of concerns about that. I think we've seen, and even in Dr. Khan's response, and I'm glad to hear that there is conversations within the medical community on ethical guidelines, but not all providers follow those same ethical guidelines. We've seen that in reporting, including your packet from the Wall Street Journal, where we have individuals placing orders for dozens of children. And so I worry Mr. Chair, that this bill is too broad, and it's not just focused on infertility as a disease and the treatment of it, but it could cover commercial surrogacy as well.
Senator Maye Quade.
Thank you, Mr. Chair. Senator Rasmussen, I'll just explain a little bit about how assisted reproductive technology works. So on line 2.3, a person's inability to reproduce without medical intervention, either as a single individual, so this would be single parents by choice who do not have a partner, they can, or do not have a partner, period, or with the person's partner. Almost all surrogates, gestational surrogates, both in the Minnesota and the state and the country, are married, and they all, by definition, have a child already. So by definition, do not experience a diagnosis of infertility. Additionally, over on 3.7, any person who is using donated sperm or donated eggs are receiving that from a third party. So my wife and I, there was a third party, a known donor, involved in the creation of our child. That is why this is included, because you can't say what people can or can't do with their embryos, what they can or can't do with their sperm or their eggs, but it does not cover surrogacy. This bill is just fundamentally, factually not about that. And I again, totally recognize that people have differing opinions about it. It is a very meaty topic that we should have a conversation about as a legislature sometime. This bill is genuinely not about that. It is about the 100 and some thousand Minnesotans who are experiencing infertility in some way, and their insurance won't cover the cost for the treatment.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Maye Quade. Would you be able to point me to where in the bill it would require a medical diagnosis of infertility?
Senator Maye Quade.
Thank you, Mr. Chair. On line 2.16, health plans must provide coverage for the diagnosis and treatment of infertility. And if you want to go to page 1.14, line 1.14, diagnosis of and treatment for infertility means procedures and medications that diagnose and treat infertility and are consistent with established published approved medical practices or professional guidelines from ACOG or the American Society of Reproductive Medicine, some of which Dr. Khan has talked about here, so the criteria.
Thank you, Mr. Chair. Thank you, Senator Maye Quade. My reading of what you cited is the coverage mandate. So if we go back to page 2, line 16, it's talking about the diagnosis of and treatment for infertility, but it's not defining or requiring a medical diagnosis of infertility in order for this to be covered. Additionally, when we go back to the page and line you cited on page 1, again, page 1, line 14, diagnosis of and treatment for infertility means procedures and medications to diagnose and treat infertility. And the challenge for me is, so to me, there isn't a clear definition of what medical infertility would be in this bill. But if you go to page 1, line 19, it says infertility means a disease, condition, or status characterized by, and one of those characteristics can be a person's inability to reproduce without medical intervention, either as a single individual or with the person's partner. And Mr. Chair, I read that if you were a single individual who wished to, through commercial surrogacy, obtain a child, that this would now be a covered benefit. And I think that's a clear reading of this language. And in fact, when you go back to page 3, line 7, it also prohibits any health plan from denying coverage to any fertility service based on an enrollee's participation in fertility services provided by or a third party. And so, Mr. Chair, I still struggle to read the bill in the same way the bill author does, given the language that's in front of us. And that has concerns for me on ethical questions and what should be covered in this bill.
Before I go to Senator Maye Quade, I'll just reply by saying I'm not entirely convinced that your interpretation of the language covers surrogacy, but it seems clear to me that the intent of the author is not to cover surrogacy. So I do wonder, as this bill goes to another committee, if there could be clarifying language that would satisfy both you and the bill's author. Senator Maye Quade.
Thank you, Mr. Chair. I will say, there's two kinds of surrogacy. There's gestational surrogacy and there's genetic surrogacy. But what you're talking about, Senator Rasmussen, is somebody going to a law firm or a surrogacy agency Nothing about health insurance would cover an agency contract for surrogacy. Your health insurance covers your medical treatments. So if you needed to have an egg retrieval, if you needed Clomid, if you needed to do an IUI cycle, if you needed to have your sperm count checked, if you needed to have your fallopian tubes looked at, all of these are medical procedures that your health insurance would cover. Nothing in health insurance would cover any sort of compensation or contract or any treatment for another person that is not you. That health insurance is for yourself. And so even if it was myself and a partner who were experiencing infertility, but I wasn't experiencing infertility, my partner was, their health insurance would cover the infertility diagnosis and treatment, not mine. So I really want to be clear that our insurance coverage, I hope we can be clear on that, is for ourselves. And that is how this bill works. It's for the medical treatment and procedures for individuals.
Senator Frentz.
Thank you, Mr. Chair. Thank you, Senator Maye Quade. First of all, thank you for bringing your personal experience to the legislative process. You share a little bit about you and your family. That helps all of us. It also informs us. You're also well informed. I'm a yes on your bill. If you can stand a compliment or two in this committee, Mr. Chair. I also want to say, we talked earlier today about tough choices. I can understand people who think this is a tough choice. I'm a yes, but I respect those who say they have another perspective. That's what we're doing here, a little bit of democracy. That's why they put us on these committees. That's why people elect us. Here comes the compliment. My first year in the Senate, Senator Dames had me in his office and said, I want to talk to you about a bill you want to bring for the liquor bill. We talked it through, and I understood what we were saying, and we came to a conclusion that we liked. I see the same thing for you and Senator Duckworth. Just want to applaud you for taking a minute to talk it through. Just an observation. Your amendment took about 3 minutes. You had talked about it, and I think that's exactly what we're looking for. And Mr. Chair, you stole my thunder because Senator Rasmussen, you have the ability to do the same thing. We talked about that a little bit today, do on the floor. I encourage members to go talk to the person you disagree with. Maybe you can work it out. And if you can't work it out, bring it here. We'll slug out the vote, and we'll see what happens. Thank you for bringing this forward. Thank you for earning a yes vote from someone who's not an expert. Thank you to your testifiers. And that's my pitch for a little teamwork, Mr. Chair. Thank you.
Senator Rest.
Mr. Chairman, I request a roll call.
Roll call requested and granted. Senator Duckworth.
Thank you, Mr. Chair, and thank you, Senator Frentz, for saving me some time and eloquently saying some of what I wanted to. We have to stop doing that in this committee. Mr. Chair, I just have one question, if that's okay. Questions for Dr. Khan. Sir, do you have any idea how many kids are now alive and well as a result of your practice and the work of the folks that you work alongside of?
Dr. Khan. So personally, I have been involved in more than 2,800 children delivered through IVF. And in the U.S., there's an estimate, growing estimate of more than 12% of the population now being because of IVF, because infertility is an ever-growing state of disease.
If I may, Mr. Chair.
Senator Duckworth.
I appreciate that. That I think gives us all some perspective. I think there are a lot of people up here that when they look at this issue and they look at the language of the bill, have really good perspectives, thoughts. You wrestle with some questions, some very large philosophical, ethical type questions. But I bring myself back to what's the intent of the bill? What is the good that it has the potential to accomplish? And the information you just shared reaffirms for me that it's well-intentioned. I think maybe some more work and improvement can be done along the way, but I think there's a lot of folks, whether they're in this committee or in this room, that believe welcoming more kids into this earth is a good thing. So that's all I've got, Mr. Chair. Thank you.
Thank you, Senator.
Senator Rasmussen.
Thank you, Mr. Chair. And I just want to make sure that members are taking a look at some of the testimony that's been provided to this committee and some of the concerns that's been raised by the letters that are including here. And again, this is from the Center for Bioethics, and in their letter they say, by redefining infertility to include individuals without a diagnosed reproductive pathology, this bill transforms infertility coverage from a treatment of a medical condition into coverage of elective reproductive services. And if you go to the second page of their letter, they have a section that talks about how this language potentially mandates surrogacy coverage. And so I think that's a major concern. I don't think we should pass the bill out of committee today without addressing this and understanding more comprehensively what this bill does. And so I will be a no vote today.
Before we go to closing comments by the author, I just want to offer my own compliments. In the past iterations of this bill, it has been confined to a certain insurance market, and I thought it was important for equity reasons that this be available to the public programs, and you have included that in the bill, which I think earns my yes vote. I would also say you have defrail language in here, which is important and appeals to the responsible members of this committee, or I guess we're all responsible, but the people who worry about health insurance costs on this committee. With that, your closing comments.
Thank you, Mr. Chair, members of the committee. I'll re-say that if we ever actually want to have a conversation about surrogacy, I would love to. I had a bill about it, would love to talk about it. But this bill, one of the common themes that you will see on all of the co-authors, both Republican and Democratic members on this bill, we are all millennials with really young children. I don't have the youngest child on this bill. That would go to Senator Duckworth. He's probably getting less sleep than I am. But this is very, very common, particularly in millennials and now in Gen Z. This is something that is affecting our generations tremendously. And there's so many life goals that we are not able to achieve for myriad reasons, but one of them is that we want to start families and we can't afford to. And this would just be an incredible step forward for so many families in the state of Minnesota to pass this bill and get it done this year. And I thank you so much for giving us time to do that and for being inclusive and bringing that forward and wanting that to be how this bill is. So thank you so much.
Thank you, Senator Maye Quade. Members who are on Zoom, can you please turn your cameras on and your microphones on to vote? The clerk will take the roll. So I should say the question is on the motion, by the way, of Senator Wiklund. That Senate File 1961 as amended be recommended to pass and refer to the Committee on Health and Human Services. The roll.
Chair Klein?
Yes.
Vice Chair Seeberger?
Yes.
Ranking Member Dames?
No.
Senator Duckworth?
Yes.
Senator Frentz?
Yes.
Senator Green?
No.
Senator Heinzman?
No.
Senator Latz?
Yes.
Senator Rasmussen?
No.
Senator Rest?
No.
Senator Wiklund?
Yes.
There being 6 aye votes and 5 nay votes, the motion is adopted. Members, there's no further business before this committee. We are adjourned.